Hello and welcome everyone for another MEDtalkx live broadcast. We're broadcasting it live onto YouTube as well as our Facebook channel and as well as Awaz 103.1 FM. So if you do want to interact with our guests and us, please do put your questions and please do like, share and subscribe to our channel. So there is a WhatsApp number for you to be aware of. It is 07522 723 455. So we will try to get your questions answered. So I guess what to expect from today, everything to do with COVID, the importance, what to expect in the new year, as well as, just a somber reflection of the fact that today we've just been notified that there's more than 53,000 new cases. So clearly this is not something that's going away. So something that both myself and Fahim, so I'm a consultant old age psychiatrist and Fahim's a general practitioner, both in the Northwest. We've been doing this for the past 8 or 9 months, Fahim. We've thoroughly enjoyed it. And unfortunately, this is actually our last live radio broadcast, but we'll continue to do our educational events. So I hope you do find the following conversation useful. And I will let Fahim introduce our guests.
Thank you, Mehran. So I wish to introduce, first of all, Dr. Omair Razzaq, who's a GP from Ashton-under-Lyne in Tameside, also in the Northwest, with a keen interest in research and medical education. A warm welcome to you, Omair.
Thank you very much, Fahim. Thank you, Mehran. Great being here.
Thank you. And also Dr. Shariq Ahmed, who's a consultant in emergency medicine at Wythenshawe Hospital, one of the foremost hospitals in the Northwest, and was a prior clinical director and member of the merit team of the Northwest Ambulance Service. A warm welcome to you, Shariq, as well.
Thanks, guys. Thanks for having me over.
Pleasure. So, Shariq, I'd like to start with you. A&E is obviously considered the frontliner for medical services. And can you give us some of your initial thoughts as to how things have been progressing for you since COVID really came onto our radar back in March of this year and now?
Well, I guess everybody's been following the news, and it's been incredibly difficult from an emergency department perspective. Ever since we started seeing the cases March onwards till now, things have progressed on and have gotten a little more difficult. We've got 2 avenues to look at. We've got sick patients, and the numbers, like you rightly quoted, are increasing by the day. We had a little bit of a dip after the first lockdown, but in the last 2 months or so, the numbers have started going up again. And similarly, we've had issues on a personal note because colleagues themselves have been going off sick and suffering with the illness. So combined with the COVID effect and the winter effect, the emergency departments have really had a tough time this year.
Okay. And Omair, coming at it from a primary care point of view, what have you found to be some of the challenges and just perhaps some of the reflections that you've had as the years progressed?
Of course, yeah. I mean, this came out of nowhere, didn't it? And something that we've all had to adapt to. And I remember at the beginning when no one really knew what was happening, how long this was going to go on for, or anything like that. It was almost a constant stream of information that was coming from 100 different directions as to what was best, what wasn't best. I mean, in some ways, we've tried to use it, to our own advantage. We've tried to become more efficient with the sort of use of remote consultations, lots more telephone and video consultations. And that's been great, but obviously that has its limitations. And from a patient's point of view, it has its frustrations as well. Because obviously the vast majority of patients will not be suffering with it, and they might not even know anybody that suffers severely from it. But obviously, as Shariq will tell you, that's not the case when you're on the acute side of it. So we will get a lot of frustration from patients in terms of, why can't we just come into the surgery? Why can't we just have a normal face-to-face appointment like we used to? But on the whole, most patients have been very understanding and have adapted with us as well. Obviously, it'll looks like it's carrying on for a while yet. I mean, initially we were, and not just us, but all of general practice and a lot of secondary care as well. We were, withholding a lot of the routine things. We were, maybe delaying the routine blood tests that we were doing sort of on an annual basis. But, we've come to a point, or past that point, where you kind of keep saying, well, let's just give it a few more weeks, or let's give it a few more months. And you have to do the best in this situation. And a lot of the routine stuff, we're trying to do as much of as we can in a safe way as possible. But it is still difficult.
Great. Yes. Thank you. Thank you, man. And I guess you did talk a little bit when Fahim introduced yourself around your research interests. Is this the time for the general public to really be aware of what's at stake and how to get involved, and how can they do so?
Yeah, absolutely. I mean, one of the sort of main websites or main sources of information that I'd encourage people to check would be the National Institute of Health and Research. It's got the list of all the different studies that are going on related to COVID, and there's a lot of them that are open to the public. Check with your GP practices and your they might be a research practice. They might be involved in some studies and things that are open to them. There's a few that we're involved with at the moment, and we've stuck to sort of just the sort of very, very simple ones from our point of view. Nothing too concerning or anything like that. One of the ones is called the Recap study, which is a remote consultation tool. So it's just a series of questions to ask people when you think that they might have COVID. And the point of that study is then to follow those patients up and see if they do end up in hospital or if they do end up on ITU, and then kind of working backwards and then seeing, was the use of that tool, could it have predicted how bad or how severe the patients were going to get? And that thing will be quite a very interesting study to see whether it is helpful, because like we said before, it does look as though COVID's here to stay. So there will be more and more remote consultation. There's going to be more and more important to do these things safely and effectively. So from the patient's point of view, that study is a very simple one. It's just a case of answering a few questions that they would answer anyway. The only difference being is that the study team will follow that patient up and then chase them up if they have, or chase up their notes if they do get admitted to hospital. But it'll all be anonymized, so they won't be taking their personal data or anything like that. Another couple of studies that we're involved with, what is called Virus Watch, which patients can sort of register on their website. The point of Virus Watch is to see how the virus is being transmitted within households and within the communities. And as we're seeing, that it does see, it is a very infective virus. And usually when it does get into someone's house, it's usually the whole family that ends up getting it. But it's interesting, it'll be interesting to see which ones don't end up getting it and why and how that happens. So that's one other study that households, whole households can get involved with. And another one that we're involved with is called a Principles trial. So that the study is mainly sort of around over 65s, where if they've had COVID symptoms recently, they might be eligible to be in the study, and they'll either get randomized to normal care or normal care plus a medication. So they were recently adding in azithromycin, but that part of the study is finished now, and they now moved on to a budesonide inhaler to see whether the symptoms do either improve, are they less severe, or do they last, for not as long as they would do in someone else. So again, it's, these will be really interesting to see whether any of these do, make a significant impact for patients in the future. And if COVID is something that unfortunately we're going to have to live with in the background, then if there are certain medications that are reasonably common, reasonably safe and straightforward that we can give at an early stage and avoid people like Shariq being overwhelmed, then all the better for it. Those are sort of the studies that our practice is involved with. There's one of the main ones that possibly people have heard on the radio or the television being advertised about plasma donation. So there's a big recruitment drive for that, to recruit patients that have had COVID. I think they're particularly looking for males and particularly Asian males who I think tend to have more of the antibodies in their plasma. So that's, again, something that's very safe, very easy for the public to get involved in.
Fantastic. Thanks, Omair. There's obviously lots of studies, lots of opportunities, and we will try to get those links from you after the show. So please do check our YouTube description to learn more about how you can get involved. Shariq, I'm going to come to you. Obviously, in acute services, that somber number of more than 53,000. It's not just in UK. Unfortunately, the trends are happening across the world. Specifically in developed countries. How do you expect the acute service to respond to that coming in 2021? And what can you say we've learnt from the first lockdown?
I think there's plenty of lessons and reflection to have from the first lockdown. And I mean, coming back to what Omair was mentioning about research projects, we wouldn't really be here if we weren't learning and reflecting from the works of countries like Italy, Germany, and even China for that matter. We learned quite early that the major presentations were related to respiratory issues. And initially, I guess you must have heard that we need more ITU beds and stuff. But as time progressed, we learned that those patients could be managed on the ward as well. And also, there was massive cohort of patients all across the region which are still being managed on a virtual COVID ward. So the patients might attend the hospital, but depending on what their symptoms are, if they're suitable to go home, we do allow them to go home, and they're followed up in a virtual environment by our respiratory teams. So that's one big positive which we've had. And also going ahead, apart from using technology to help assess patients, we also have ideas as to how to use auxiliary services and other wards which have been created. So the government has been really good over the first period to create spaces like Nightingale wards and other units all around the country, which can absorb pressures. Because one of the major issues is that from the first lockdown, we literally had to shut down all hospital services, and even primary care had to stop all day-to-day activity. This cannot be, because by any margin, COVID doesn't seem to have an end point to it. So one of the major factors to learn from and to have put in place is a preparedness for 2021. And hopefully, with all the lessons that we've learned, we should have some things in place.
Excellent. Omair, I want to come back to the research part, because that is a strong interest of yours. Just to play devil's advocate, imagine you're someone listening to this show and you think, what's in it for me though? Why should I get involved with a research project, And apart from remuneration, how would you convince them to actually get involved? And because they might be thinking, it's not going to benefit me, it'll benefit people in the future or something. But, I'm interested in myself at the moment, So can you give us a rationale why people would get invested into it?
Yeah, I think the main thing is the more we get to know about this virus, I and the quicker we get to know about it, the quicker we can all get back to normal. You know, obviously, when there's debates about lockdowns and you know, tier 3, tier 4, tier 5, tier 6, and whatever, the main thing is that we're not controlling the virus, and not only are we not controlling the virus at the moment, it's that the hospitals, the secondary care are being overwhelmed. The ambulance service is being overwhelmed. The whole health structure is at breaking point in some certain circumstances. So the more people get involved in all these different studies, the more we'll get to know about it, and the more we can all get back to normal, start enjoying our lives, meeting friends, meeting families, going to the cinema, the restaurants, and whatever. And I think that's the main reason to be getting involved in all this. So even if we do just a small bit, even if it feels like we've not done a massive amount, like for example, that the remote consultation study I was saying, the patient might not even know that they've done anything, but if it helps GPs like myself and other doctors and nurses consult in a safe and effective manner, then the more we can get back to normal. Like Shariq was saying, we can't continue with being closed, whether that's primary care or secondary care, because other diseases are still around. They still need treating. People are going to develop new problems that still need managing, but it's going to be more and more difficult the longer this goes on, and the slower we get to know about these things.
Okay. Shariq, you're one of the first A&E consultants we've had on our show. So I'm going to mention something. Back in April, there was an A&E consultant who sadly died, Manjeet Singh Riat. I don't know if you know him, but from Derby. And he was the first Sikh consultant in A&E in the UK. And I was just saying, obviously, I was really saddened to hear about it, but I read about his life story and his obituary and so on. And obviously, I've worked in A&E before. And Shariq, how do you cope with the frenetic pace of it and still bearing in mind, there's been colleagues of yours like, Manjeet, who've died, and how do you manage your emotions as well as the hectic pace of A&E?
It's quite difficult because when we were in training and when we were juniors, it was about the end point of a shift and then you would go home. But when you get to a senior level, and particularly when you're a consultant, say you're on call, it becomes more and more difficult to actually keep on absorbing all the pressure, because there comes a time where even the best of sponges would come to a limit. So it is quite difficult, but luckily times have changed, and both mental and physical well-being is being strongly advocated in the NHS. And I'm sure it's the same in primary care as well. So all the Royal Colleges are really taking it forward. Maran's an old age psychiatrist, so I'm sure he's aware of measures as well. We've got professionals for the mental and physical well-being for staff in the hospital. We do drop-in sessions for all our staff, and it's just about trying to get to symptoms early. I guess one of the biggest problems which has happened with COVID is that all the stuff that you as an individual would look at or do to sort of vent off or let the steam out are things which you're not able to do. So you're not able to go out. There's no cinema. You can't meet friends. You can't eat out. So it's like a double whammy of sorts. It's been work and home, and like everybody's a little more frustrated. But I guess these are the times when your resilience has to really hold up, and you have to avail services which are available to help you cope with these circumstances.
Yeah, and I absolutely agree with that, Shariq. And that's where I think those kind of social circles have changed. You rely on colleagues a lot more. You invest a lot more time, both emotionally as well as in terms of energy. So it's really difficult times, but I must say there's an increasing amount of resilience within the system. But you're absolutely right about the need for mental health and well-being. There's obviously Dr. Adrian James has talked about the importance of increased investment because we need community provision. Ultimately, that's where we want to manage COVID and its associated syndromes. So we're getting questions coming through. So I'm going to show this to yourself. So this is for you, Omair. So has talked about, has COVID changed the way consultations are conducted in primary care for good in terms of remote consultations, which you talked about earlier? Is this something that's here to stay?
I think, well, I can't talk for all GP practices across the nation, but for us in particular, I think it's been a really efficient use of our time in some ways. And definitely it's going to be something that we're going to carry on with. Obviously, we'll end up doing a lot more face-to-face consultations, as time goes on and as the rates go down. But having said that, we are doing them now if we need to. So it's not as though our doors are completely locked and nobody's there. We've been working pretty much as normal since March, April time. So yeah, there've been a lot of advantages with using remote consultations, not only for ourselves but for patients as well. They can go about their daily business, they can go to work, and it might just be that they've just got to take 10-15 minutes out while they speak to the doctor or the nurse. Whereas before they might have had to take the full day off, really, because to make an appointment. So from that aspect, there's definitely advantages to what has happened, and some good has come out of all of this terrible virus. But remote consultations, they do have the challenges, of course. You can take a good history, but sometimes you do need that face-to-face contact with a patient just to get a feel for how they're feeling. And Mehran, you as a psychiatrist will probably know better than me in terms of how important and how vital that can be, just to give you a feeling of whether a patient is really unwell or if they're actually okay. But yeah, definitely a lot of advantages that have come out of it.
Great. So keep those questions coming. I'm going to try and move the topic on a little. So Shariq, if we talk about the new strain, it's fair to say we knew a little bit more about it towards the end of September in Kent, and then another case was picked up in London the following day. What does the public need to understand, and how is it different to the previous strain?
Yeah, so it's quite an interesting thought, because the first time it got looked at was, like you rightly said, in September. And the reason why it's just become more topical is because all of a sudden in December, earlier on, there was a spike noticed in London, the southeast, and the southwest as well. And when they looked into what was potentially behind it, that's where the new strain came out. And that's where Matt Hancock tweeted and came on the news and said that, well, there's a new strain and that's what's causing the problem. And hence the fact that travel out of UK around whichever other countries there are was banned. The biggest issue is that every virus will have variants, but the new strain is more dangerous because of the high degree of transmissibility that it has, and hence the fact that there's been this massive spike in the south. And I think, according to some reports, around 60 to 70% of the people who've been newly infected are found to be infected with the new strain.
Yeah. So, and there's some suggestion that the R value is high with the new strain. So, for the general public, could you tell us a little bit more as to what we mean by the R value and why is this important, Shariq?
So the R value is a number which a simple explanation would be that it's how many other people can one infected person infect, and that's how the R value is calculated. So to put it into context, it's about taking the value of one person and then measuring how many other people he may have contacted or been infected with in 30 days and then again in 60 days. And that's how the R value is calculated. Ideally, we would like to keep it under one, and hence the first lockdown was instituted because back then, before the first lockdown, the R value was running around 4. And right now, in highly infected areas, it's running around 1.3 or 1.4.
Omair, you've got some questions coming in for you. Some of them are a bit entertaining, but let's take it, shall we? We aim to be entertained as well as educate.
Of course.
So, Dr. Omair, can you please reassure the general public that the vaccine is safe and healthy? Your hair looks good. So I would agree with that second part. Yeah, a little bit about the vaccine for your idea for us.
Yeah, of course. It's been whenever there's a new drug that comes onto the market, it gets thoroughly tested. The regulatory authority that we have here, they don't just pass through drugs and vaccines just for no reason. It is very safe vaccine so far. We haven't come across many or any sort of major issues or anything like that. But of course, it is a brand new vaccine. It is a brand new medication to give someone. So obviously, only time will tell how effective it is and how good it is. But so far, so good. It's like having the flu jab. In terms of the side effects that you might get. So you might get a little bit of a sore arm, might feel a little bit under the weather for a couple of days after you have it, but that can happen with any jab, any immunization. As the vaccine is being rolled out across the country in different ways. There are some areas where each GP practice is being involved in giving it to their own patients. In other areas like ourselves, it's being done more centrally. So the patients are being being texted out or being sent invitations to book their appointment at a hub, and then they'll go there, have the jab. Little bit different from other jabs in that they are asking patients to wait for 15 minutes just to make sure that there is no acute reaction before they go on their way. And there's, at the moment, there's a second dose that they need to have a few weeks later. It might be that the protection only occurs sort of a week or so after that second dose for a lot of patients. Whether new vaccines come out over the next year that are different, that only need one dose, who knows? But that's the one that we've got at the moment, and so far so good. We've had a lot of patients ringing us up at the practice asking when they can get it. So there's definitely an appetite to have it done, and hopefully we can get as many people vaccinated as quickly as possible.
Yeah, and I would like to add to the fact that from a hospital perspective, it's been a welcome relief for all clinicians and nursing staff, everybody in the front line who's been waiting for a bit of respite over the last 9 or 10 months or so. This has been the best news ever. I can't really talk about the whole of the country, but say for the trust I work at, most of the Staff have now been offered appointments, and quite a few of them have had vaccinations as well. Touch wood, so far I've not heard of a single untoward incident. So I would definitely advocate, if you're giving the opportunity, please do get the vaccine.
Excellent. That's a good message to send out to the public. Shariq, there's a question coming for you. Question says, I wonder if remote consultations and primary care have affected the inflow of patients in A&E, and as the burden on secondary care increased, not just with COVID-related symptoms. Slightly leading, so let's just change that to how has it changed? What's happened to A&E with the remote consultations? Can you give us some insight to the viewers and listeners as to how that's changed with remote consultations coming into primary care?
So by and large, as Omair mentioned, people have been quite receptive to remote consultations. It has increased the burden on primary care in some ways, but overall, the emergency departments have been quite okay coping with the GP type patient. There's been a greater reckoning in the public because now people are calling NHS 111, they are contacting the GP via Ask My GP, and they're attending their pharmacists, so forth. So yeah, people don't really just turn up to the emergency departments. However, we have seen a certain group of people with recurrent attendances and mental health, which come to the A&E more often because those are the sort of people I would think would benefit from more of a face-to-face consultation. And I guess Omair has probably already said this before, and so has Mehran.
Great. So I'm going to try and continue this conversation about vaccine, and it kind of follows the question from Faisal around the vaccine and how effective will it be on the new strain. So if I pose that question to Omair, what do we know about, I guess, the new strain and the efficacy of the vaccine? And when we talk about efficacy, what do we actually mean by it?
Well, essentially, I think we just mean effectiveness. Is it doing what we need it to do? So, you know, I mean, so far it looks as though the vaccine will decrease the severity of the illness. So if we have the vaccine, but we unfortunately then get the virus, we're unlikely or less likely to suffer severe effects and end up in A&E and ITU and things like that. We don't know, or we don't think that it really helps in terms of the actual transmission rate. So I suppose added on to us being quite positive about the vaccine before, it is still important that people still, do wear masks, use hand gel, and continue with social distancing, because I think a lot of people may be under the misconception that if they get the vaccine, then they're okay to visit their more vulnerable friends and family, because they won't pass it on to them. But we don't think that's the case yet. In terms of the new strain, we don't know massive amounts about it at the moment. It's not been around that long, but the consensus at the moment seems to be that there doesn't seem to be any change to the types of symptoms that people get or the severity of illness that people get. But it does seem to be a lot more effective, as Shariq touched upon before. So in terms of linking that into what we were talking about before and the R rate, it's even if the R rate stays as it is, if the number of cases is then increasing and increasing, it's going to lead to overall a lot more patients being infected. Whether the vaccine is effective against the new strain, again, the press releases from the relevant drug companies, they seem to be confident that it should cover different strains, but I guess only time will really tell. If it is anything like, say, the flu vaccine, where there are different strains of flu, it might be that we're not 100% effective against all the strains, but only time will tell.
Right. Thank you, Omair. And Shariq, you talked about the schedule for frontline staff on getting the vaccine, but for the general public, once we address the vulnerable groups, which I guess it's the elderly as well as as you mentioned about the frontline staff, when are they expecting to be offered the vaccine?
So I guess every trust is different. And I can't really comment on other ones, but most of the hospitals and the trusts that I know of in Greater Manchester, at least, have offered appointments to their frontline staff. We were lucky to get it last week, and we're scheduled to have a second one done in January. Still, the risk is there because you're dealing with positive patients on a day-to-day basis. So you have to be careful. You have to, wear the appropriate PPE and make sure you're careful with things. But as far as I know, quite a few hospitals around the country, at least, have offered frontline staff the opportunity to have the vaccine.
And just about the public, Shariq, when are they? I know you talked about the trust and obviously the health professionals. They have they're led by certain decisions by the trust, but I guess the general public, when would they get offered?
Oh, that's a difficult one to tell because I guess Omair might be a better person to answer that. There probably is some element of a risk stratification in place, like you mentioned. So the high-risk patients and elderly would be the first ones on. Even that would take the next couple of months. But as to vaccinating the whole country, that's a mammoth task.
Yes. Sorry, just to interject. It is being rolled out in stages to different cohorts of patients. First group are like the over 80s, care home residents, care home staff, and healthcare staff. And then I suppose it's just working their way down those different groups. So after that, it'll probably be the over 75s, then the over 70s, and the clinically extremely vulnerable groups, and then they'll probably just sort of keep going younger and younger. And in total, I think there's 9 groups that are there, sort of just going down in terms of age order, particular in terms of the general public. And again, it might end up being like the flu vaccine, where if you're someone who's relatively low risk, young, no health problems, things like that, then it might be that you don't get offered it. Who knows? But as things stand, I think there's probably enough of a task trying to vaccinate all the relevant, all the more vulnerable people and all the elderly people, which is going to be a task in itself. And especially with it needing the 2 doses, the 15-minute wait, all these things add up. Whereas in 15 minutes for him, you might back me up on this. In 15 minutes, you probably could give 5 or 6 flu jabs in that time. With if you were doing a flu clinic, so those sorts of things will definitely have an impact in terms of being able to deliver it to everyone.
Excellent. We can't not continue. We've got to extend professional courtesy to our GP colleagues asking questions. So one coming your way, Omair, from Dr. Harris. That's, would you endorse a full national lockdown for January, February to cover a tough winter period? I think this is an interesting question. There's a lot behind this because the concept of lockdowns, we've not really discussed it yet, but actually, what is your thought about it, Omair? There's different varying opinions. Some people think that a lockdown means that it's a failure. Other people think it's necessary. So how do you feel about that? Do you think it's imminent, and would you endorse it, as the questioner asks?
It's always a really, really tough question to answer that. Obviously, from a healthcare point of view, and just looking at a point of view from the effects that this is having, especially on our colleagues in secondary care and A&E and ITU and places like that. A lockdown probably would be something that this should be on the cards. And if we think that the rates, like Mehran was saying before today, are the most amount of cases that we've had ever, and we were in lockdown back in March, April. So logic kind of says, well, if we're in a worse position than we were then surely we have to lock down. So from that aspect, it does make sense as to why we possibly should. I know that there's obviously the economical question in terms of lockdown. Again, I'm not an economist, but is the short-term lockdown going to be cheaper than the long-term several lockdowns that we potentially are going to face? It's not an easy one to answer that, and I don't envy the people in government, making these decisions. But would I endorse it? Anything that would potentially make us all safer? Yes, I would endorse.
Okay, Shariq, I want to come to something topical that I've been reading about, and I'm sure a lot of our listeners and viewers have been, and that's the concept of contracting COVID when you're in hospital. I'd like your perspective on this. The Health Service Journal, which covers policy and management in the NHS, they did an interesting piece back in 18th of December saying that the number had risen by more than a third in that week, and so there's a huge number who may be getting it as a percentage. Now, if you're a potential patient at home and you're having an emergency, I know from discussions, some may be quite wary because they consider I may get COVID and I'll just stay at home. What would you say to allay their fear in terms of some of the safeguarding measures that you take to prevent potential patients or patients who enter your department from getting COVID?
Yeah, I've just read that article as well, and I'm like, it's unfortunate to know that the hospital-acquired infection rate, particularly for COVID, has gone up. All I can do is basically try to reassure the public that the NHS is there for them from the very doorstep, starting with patient factors. Any patient who's coming into the emergency department is screened even before they've booked in, to ask about their temperature, symptoms, travel, any possible contact. And if there's any symptoms at all, those patients aren't allowed to mix with any other members of the public sitting in the waiting room. They're streamed directly into special areas of the department, which we hold for COVID patients. And from there onwards, naturally, if the patient is deemed to be at any risk of having COVID, they go to a special ward. They don't get put in a ward or next to a patient who may not have COVID. And from a staff perspective, naturally, there's measures in place, like at Manchester Foundation Trust, we've got Shine in Your Uniform. So we're not allowed to, or staff is not allowed to attend the hospital in their uniforms. So you come in your own clothes, you change at work into scrubs or uniforms. You always observe the right personal protection equipment, hand washing, personal hygiene. Those things are absolutely paramount, and regular audits are carried out for those lines. And on top of that, staff, particularly at our trust, are having twice weekly tests done. So we've all been issued lateral flow testing kits to check for symptoms. Sorry, if with or without symptoms, you do a personal test just to make sure you don't have any signs of infection.
Great. And Shariq, do you have a message for the listeners and viewers about upcoming New Year? Traditionally, that's a time of perhaps hedonism or enjoyment, celebrations, festivities. But I think this year's a bit different. People have had to curtail some of the things, maybe for bonfire night and so on. Do you have a message in terms of to the public about how they should celebrate it in a different fashion this year?
I think the best part about the British public, regardless of ethnicity, has been how resilient and stoic they've all been through the last 9 or 10 months. Even though I wouldn't say that there's a clear end in sight, I would say just hang fire, just hold on to things, stay safe, stay at home. help with the NHS, and yeah, hopefully we'll see this thing through in the next year.
Great. And Omair, I'm going to try and pose more questions. The flooding in. So I'm going to try and combine two. So one is from Riaz Khan, who talks about the regional differences, about the vaccine being given within NHS England, and the importance of ethnicity. And we also have a listener asking about areas such as, let's say, East Lancashire, where a lot of our listeners on the radio actually reside. Would they be targeted in the sense that they are the most vulnerable population, and hence vaccines will be offered? I don't know what your thoughts are on that.
So is the question? Sorry, is the question in terms of should the NHS staff of Black and Asian minority groups be offered the vaccine first? Is that correct?
I guess are they one of the vulnerable groups, and should the distribution be with them, and then subsequently to later lower risk groups?
Well, I mean, I suppose from what we're touching upon before in terms of how the vaccine is being rolled out, it is with that thought of, the more vulnerable patients, the more elderly patients being the first in line to get it done. The clinically extremely vulnerable patients will be sort of towards the top end as well. From that aspect, they haven't sort of used ethnicity as one of the criteria to be getting the vaccine. Whether that should be the case or not, I'm not 100% sure. Obviously there is a lot of data to say that yes, patients of Black and Asian origin are potentially more vulnerable for various reasons. But I'd go back to what Shariq was saying before about trying to stay safe, trying to sort of do your bit anyway. So even if the certain population, if you believe you are at a more vulnerable, in a more vulnerable category, you just need to be a lot more careful about it for now, regardless of whether the vaccine comes to you first or not. These decisions can take a long time to come through. But we need to be acting in a responsible manner for ourselves now. And if the vaccine comes along a little bit quicker, then great. But I think, we need to act as though when we go out, when we're at home, best thing is to act like you've got it. Act like you've got it. So, you're reducing the chances of passing it on to someone else. And act like other people have got it and you haven't. So, wash your hands, wear your mask, maintain your 2 meters. And if you do that, if you stay like that, then the chances of getting anything are minimized regardless of the vaccine. So I'll probably fudge that question a little bit there. But
yeah, no, I think, I fully agree with that. So no fudging, but there. But I guess I'm going to try and put this question to all of us. So when this debate will be having the vaccine? So hands up.
Yeah, I'm happily go for it.
Naran, your hands
I'm just testing your faith, right? Of course, no. It's given what we've experienced since beginning of this year to where we are today, to actually be in a position to actually be offered a vaccine. What's the alternative? I guess that's my take on it. I guess the other question is, which vaccine would you have preference for? But I guess that isn't the question. But yeah. Go on, Shariq, you're about to say something.
I think like the flu jab, considering the variants that are coming on, there's a high likelihood we'll be having one every year. So we might as well start with whatever's on offer.
Yeah, no, absolutely. And if you look at the new strain, then they talk about the growth rate being more than 70% compared to the previous strain. That doesn't mean it's 70+% more transmittable, but certainly it means it replicates and develops at a much faster rate. So what that means in the future, only time will tell. I'm going to come back to you, Shariq. And in terms of A&E and presentations, what have you noticed that hasn't really come to the shop floor as much? And what kind of cases do you worry about that perhaps they're either not attending A&E quick enough or not attending A&E at all?
It's very much been a generational thing. I really worry about the elderly population more. The first lockdown in particularly, I mean, we hardly saw any regular patients coming through, but there was a lot of COVID patients. But then things have sort of virtually hit a plateau. But people at home who may have had transient ischemic attacks, um, resting angina, strokes, and well, because there's been such a lot of hype about not attending hospitals, by the time people are coming to hospital, particularly of a certain age group, again, it's far too late. So yeah, I'm like, those are the groups which I'm really worried about, because they're really reluctant to come in. They really follow the government guidelines to the letter, and sometimes it's well, bad for their own health.
Yeah, I think. Sorry, just adding to that from a primary care perspective. I think it's a similar kind of thing as well, where patients might be, having a change in their bowel habit, or there's a lump that they've just noticed, and they're kind of saying, "Well, I'll leave it." But there's no reason to. Try and encourage all the listeners and viewers to say, look, if there's something you're concerned about, please do contact your GP. Please do get a review done. I mean, for cancer referrals, a lot of them can just be done via history, and it doesn't always need an examination. But if an examination is needed, most practices will be doing face-to-face consultations, obviously in a safe manner, as similar to what Shariq was saying about A&E patients. So there's no reason why patients should fear picking up the phone or going through their online consultation or whatever to put in their worries to get their symptoms checked out.
Omair, obviously you work in primary care, and a lot of primary care is to do with prevention. Often in terms of prevention is better than cure. And I think the pandemic has taught us many things, but one of them is the inequalities in society and how they can have a negative effect on your health. For instance, socioeconomic deprivation, poverty, etc. Sometimes living in congested or cramped housing and so on. What have you, or maybe your practice or other GPs been doing to try and level the balance and level the playing field for patients by using this pandemic as sort of spurred on by the pandemic? Have you done any measures or anything to reach out to these hard to reach communities, perhaps?
Yeah, I mean, it can be very, very difficult. I mean, one thing that we've tried to do is to implement online consultation to improve our access and improve the chances of patients getting in contact with us. That in itself can lead to inequalities for patients who are not necessarily IT literate, or in, like you said, in lower socioeconomic areas there might be issues with having internet access as well. So that in itself has its own problems, but it's another avenue for patients to be able to contact us. We're trying to use social media and YouTube a lot more to be able to send out messages, to be able to send out so things like there was Breast Cancer Awareness Month. One of my partners did a video there. We tried to sent it out to patients. Similarly, we've tried to carry on with as much routine stuff as we can, or pick it up again. So we've got smear clinics on. We're doing the routine blood test to pick up on patients with cardiovascular disease that not necessarily been diagnosed with it before. And a lot of these things we can do, remotely as well. So it doesn't always mean that you need repeated attendances to the GP practice. We're encouraging a lot of our patients to get oxygen monitors and blood pressure machines to try and reduce those inequalities, so they're not just relying on one appointment every 6 or 12 months to see whether their blood pressure is okay. And in the context of COVID as well, having these sorts of equipments at home could be a lifesaver.
Yeah, some really good points there, Omair. Shariq, coming to you, obviously you're an A&E consultant and you must be dealing with maybe staffing issues and so on. We all know a lot of people have been sick and so on. How are you actually trying to manage that? I know there's been reports in the news that sometimes in some of the London hospitals they were sending out messages, if you're free for a shift, come along and these sort of things. I mean, how do you actually try and manage this whole workload and spreading it out and making sure the shop floor is covered, and also balancing that with mental rest and also preventing further burnout in the A&E speciality itself?
Yeah, I would like to start with the staffing question. Naturally, it's been a bigger challenge, not just because of COVID, because also of the holiday season. You've had colleagues go off sick, and there's always, I don't think there's a day goes by when we don't have a deficiency or two on the rota. But what we generally tend to do is we look at the heat map and see how many attendances are coming in on a daily basis, hour by hour, and based on that try to level out our staffing so that it doesn't become too much of a burden on just the people who are working there, and that itself helps prevent the burnout aspect. And like I mentioned before, the staff who are already working in the department, there's lots of help and support available to them. With the well-being team, there's clinical supervisors on board, there's senior consultants on board to help support the juniors. Because in between things, life cannot stop. So when the first phase hit us, we stopped all rotations. Junior doctors were staying put into where they were, but actually we have to look at all those aspects, and life has to move on with things. So junior doctors do rotate, and everything else happens. Plus, technology has helped a lot. So everybody is now on a WhatsApp group. So whenever we have a deficiency,
or several,
or several last minute or otherwise, whether it's nursing or doctors, it goes up on a group. And it does get covered, thankfully, because the team working and the camaraderie has been excellent over the last couple of months and years. It's really built up, and it's really people have really come up to the plate, especially over the COVID crisis. So it's still a massive challenge. I'm not saying that we're home by any means, but we're getting there. And yes, sometimes things are really harder than what they normally would be, but we hope that we'll be able to cope with things.
Great, thank you, Shariq. And we usually tend to finish off in our customary 3-tip style. But just before we do that, I just want to thank, again, all our audience. If you do like and appreciate what you've watched and heard, please do subscribe to our channel as well. We've had a huge array of guests, and they've all shared their time. And we really do value the listeners as well, because without your engagement, this doesn't really, it doesn't fit with both me and Fahim in terms of the quality and the relevance of what we're doing. So I hope it's made a difference. And I'll start with yourself, Omair. So 3 tips. What can you share with the public?
Hands, face, space. We'll count that as 1 tip. But I think the main one is stay positive. Stay positive. So if we do get locked down again, we've just got to think. Look, the better we stick with the lockdown, the quicker it'll be over, and the quicker we can get back to normal. Try and sort of use any kind of situation to your own advantage. So if we are locked down, take it as an opportunity to catch up on housework or get yourself fit, get yourself, healthier and things like that, which are going to help in terms of if God forbid any of us do catch COVID. So, be positive, take circumstances into your own, for your own advantage. And what I was touching upon before in terms of if you're worried about any health issues, if you're worried about any symptoms that you may have developed, but you're scared of attending the GP or even A&E or whatever, don't be. Please contact us. Please, get yourself checked out to make sure that you are as healthy as possible.
Fantastic, thank you. And Shariq, 3 tips.
Yeah, pretty much the same things, but yeah, I would say, like, do utilize the services which are available to you in the community. There is Ask My GP, and GP services are open, so even if you pop a question, it will get answered sooner rather than later. There is NHS 111, so unless there's a dire emergency, instead of dialing for an ambulance, do contact those services, and they will direct you to the right responsible person. And yeah, I suppose like it's all about staying home, staying safe, protecting yourself and protecting your relatives, and by that you're protecting the community. And yeah, get the vaccine done as well if you do get offered the opportunity.
Lots of tips there, Shariq.
Yeah, it's more than 3. But
yeah. Oh no, it's fine. But yeah, I guess just thank you again, Omair and Shariq, for sharing a Tuesday evening. It's been really great to have you both on board, sharing your own kind of experience and expertise. And just for our watchers and listeners, please be aware we are continuing a kind of educational platform, but not on every Tuesday 8 to 9. So we have got organ donation, fostering, skin disorder event, and hopefully a long COVID all for January lined up. So stay tuned, and I'll leave the closing remarks to yourself, Fahim.
Well, thanks, Mehran. Yeah, that's why we didn't really touch on long COVID tonight, because we're hoping to dedicate another full session. I want to put my heartfelt thanks both to you, Shariq and Omair. Obviously as healthcare professionals as well, you're doing a great job out there. Thank you to all the listeners and viewers. It's been a long journey. I won't get too emotional tonight, but we've really enjoyed it, and hopefully we've provided some value in terms of education and a little bit of entertainment along the way. And really just keep tuned in. I also want to plug that we do have a book club as well that we do every month. So that next session's coming on Sunday. We're talking about Jordan Peterson's 12 Rules for Life. It's only a few days away. So that's at 8 to 9 p.m. usually last Sunday of the month. But on this occasion, this Sunday for the Christmas holidays, we've just changed it slightly. Thank you again so much. And very good evening to everyone watching and listening. Thank you so much.